Hello and good evening, friends. Today is the second talk of the resident series of the ACNS webinars for the month of September. Today, we are blessed with the presence of a great personality with us who is considered to be the teacher of the teachers of the present generation of neurosurgeons. Ladies and gentlemen, may I please introduce you to the Director of the Skull-Base Surgery and Cerebrovascular Surgery, Professor and Vice Chairman of the Department of Neurological Surgery, University of Washington, Professor Laligam Sekhar. Professor Sekhar, who has his deep connections with India, currently works at the Harborview Medical Center and is a world-renowned neurosurgeon and researcher who has given several contributions towards neurosurgery. He was the past president of the World Federation of Skull-Base Societies and also the past president of the Washington State Association of Neurological Surgeons. His various descriptions about various approaches and classifications of tumors are followed by most of the neurosurgical centers around the world. His descriptions about meningiomas of the cavernous sinus is one such example of his many novel and interesting contributions towards neurosurgery. Professor Sekhar is going to talk about the current approaches to the management of tumors involving the cavernous sinus. To chair this session, we are glad to have with us Professor Miki Fujimura, who is the Director of the Advanced Cerebrovascular Surgery, Konan Hospital, Tohoku University of Graduate School of Medicine, Sendai, Japan. We are so grateful to Professor Fujimura to have accepted this invitation to chair this session, in spite of this being a very odd time in Japan. Professor Fujimura is an active member of the Japanese Neurosurgical Society and also a keen researcher who has a special interest in microneurosurgery for cerebrovascular diseases. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I hereby welcome today's speaker, Professor Laligam Sekhar, and Chairperson, Professor Miki Fujimura, to this online platform of ACNS webinars. Dr. Liu Bunsang from Malaysia is my co-host for today. And with that introduction, may I please hand over this online platform to Professor Fujimura.
Hello, good evening, everyone. It is my great pleasure to chair this very special session. It is my great honor to invite Professor Laligam Sekhar, the great neurosurgeon, and he's going to talk about the current approach to the management of tumors involving the cavernous sinus. So, Professor Sekhar, would you start your lecture, please?
Thank you very much. I think you need to go back to my screen. Good morning. I'm going to just quickly go over some of the easy parts, that is the information that you already know. And then I'm going to talk about what is our current approach. So the space called the cavernous sinus is actually a plexus of veins around the carotid artery, which lies on either side of the sella turcica, and it has got very rich connections with other veins, venous sinuses, and veins of the brain. Now, although hundreds of triangles have been described in regard to the anatomy of the cavernous sinus, I consider these to be meaningless because in the practical situation, you cannot see the triangles that are seen in an anatomical dissections. So I consider the cavernous sinus to be a truncated pyramid, and you can see the apex of the pyramid to be oriented towards the orbit, the base oriented towards the clivus, and then it has several surfaces. So you have the lateral surface, superior surface, inferior surface, and the medial surface. And you need to be, of course, the only crucial structures inside the sinus are the internal carotid artery with its branches, the abducens nerve, and the sympathetic nerve. And one can approach the cavernous sinus from any of these sides today. You can come, for instance, by a transsphenoidal endoscopic approach on the medial side, a transpterygoid approach coming from the inferior side. You can approach it from the posterior fossa side, very commonly from the lateral or the superior sides. And of course, if you have a tumor of the orbit, you can trace it back from the anterior side. So with apologies to some of the illustrious people that have described various surfaces and some of the younger people who have over enthusiastically talked about hundreds of triangles, I'm here to tell you that in the practical situation, they do not make any sense. So you just need to find the nerves or find the best way to get in and remove the tumor. So these are all some anatomical dissections. I won't go over them in detail, but here you can see the inside of the sinus, which has got the abducens nerve and the sympathetic nerves, and the two major branches here, the infralateral trunk and the meningohypophyseal trunk, and then the peeling of the lateral wall, etc. So what is so tricky about the cavernous sinus? Location is deep. Venous bleeding can be frightening. Injury to the carotid artery, which is the worst thing that can happen, can result in a major stroke or death. Injury to cranial nerves can create permanent problems with either vision, double vision, etc. You can have brain injuries from retraction or direct damage, hematomas, etc. And then entry into the sphenoid sinus or an approach to the sphenoid sinus can result in CSF leak and infection. There have been a number of advances in evolution in cavernous sinus surgery, starting with the works of Parkinson, Dolenz, and many others. The first one was further knowledge of anatomy. The second were the development of systematic approaches from different sides, as I described. One of the major advances was how to control the venous bleeding. We used to do this in the past with packing with oxidized cellulose. Nowadays, we do this by just reducing the bleeding with some temporary packing and then injection of either fibrin glue or powdered gel foam. And this is very effective. However, one has to be careful that you don't inject too much because then it can reflux into the major sinuses. The dissection of the carotid artery in the sinus, and more importantly, the bypasses that have been developed to bypass the lesions, arterial lesions. These have had a major impact on the approaches and the outcome. Cranial nerve dissection and repair have also evolved. However, the repair is still incomplete, or the recovery is incomplete in many patients after repair. It is critical to perform proper reconstruction to avoid CSF leakage. And then we have also the evolution of microsurgery, endoscopic surgery, and endovascular surgery, all of which are utilized for lesions of the cavernous sinus. And finally, radiosurgery also has an important role to play. And the eye muscle surgery, so working with the ophthalmologist, the neuro-ophthalmologist, and this can be very important for the patient afterwards. And however, the long-term results are still dependent upon the pathology, as you will see. So a few words about the results of radiosurgery and radiotherapy for meningiomas in particular. And there is no doubt that radiosurgery has an effect on meningiomas, particularly definitely in the skull base. And I have shown here in this slide the results of radiosurgery, but it also has some degree of permanent morbidity, and there's a potential for recurrence of tumors. So if one is going to treat lesions with radiosurgery, it is ideal to have an idea about the pathology, first of all, and secondly, to reduce the tumor volume or bulk so that you can reduce the amount of field that is getting radiation. And for certain malignant tumors, fractionated or proton beam therapy may also be utilized. And when you use particularly fractionation or proton beam, there are cognitive, neurological, neuropsychological deficits that may occur with patients. So what has changed as well is that as the approaches have evolved and our modalities of treatment have evolved, our patients have also evolved. So they demand what one may say less invasive approaches and better results. For instance, today, carotid cavernous fistula is almost always treated by endovascular treatment. Paraclinoid aneurysms, the majority are treated with endovascular therapy, except for ruptured ones may still be clipping them, but a lot of unruptured aneurysms are often treated by flow diversion stents, sometimes other types of stents with coiling. Intracavernous aneurysms, of course, the treatment indications are still very much a topic of discussion, but the ones that are treated, the majority are treated by flow diversion. Bypasses are still utilized for failed or unsuccessful cases. In case of neoplasms, we have discussions about complete versus incomplete removal, radiation versus radiosurgery. We also have options of both microsurgery and endoscopic resection. But the goal of all of these, the combined modalities, is that you want to achieve the best possible result for the patient, both in terms of their functional recovery as well as the long-term results for the patient in terms of the tumor. So both, it's a balance which you have to achieve. Now, there are some preoperative and intraoperative checklists that I use for these patients. Preoperatively, it's important to know what is the patient's occupation and what are the expectations. You need to have a good examination, particularly of their cognition and cranial nerves 2 to 7. MRI scan, of course, is a major modality. CT scan, particularly with bone windows, is very useful. And for larger tumors, we still perform angiography and sometimes embolization if it's possible, not usually possible. And in terms of collateral circulation, generally, we simply do a carotid compression, common carotid compression in the neck with contralateral carotid arteriovertebral injection. This gives you an idea of the collateral circulation, not about whether you can do a permanent occlusion, but can you temporarily occlude the carotid. For instance, if you have an isolated circulation, even temporary occlusion of the carotid may result in major deficits. If you are planning a bypass, then we start the patient on aspirin or clopidogrel before the surgery. Intraoperatively, we like to have a central venous line most of the time, and question of blood typing and crossing. Neurological monitoring, we mainly monitor SEPs, MEPs, and cranial nerve 7, but some are still monitoring the third and sixth nerve, which is a technique which I innovated many, many years ago, along with Dr. Agi Moeller. We like to obtain proximal control of the carotid for most of the tumors, cervical or petrous carotid. We often use orbitotomy, but we may not use a full orbitotomy. We have just the entire orbitotomy for larger, for when the vein is full, or we may just use what's called a posterolateral orbitotomy. Zygotomy is used when the tumor extends into the middle fossa. It's important in every case to have clinoidectomy, and this could be extradural if possible, but sometimes you have to complete it intradurally, and this is more important when the clinoid is very large and or for vascular cases. Optic nerve decompression is still important, and when you remove the clinoid, you have to pay attention to whether or not there is potential for CSF leak through an air sinus, sphenoid sinus extension. Then finally, the strategy of tumor resection is important. How you're going to get into the tumor and going to how you'll remove it without damaging other structures. And you should have temporary clips and bypass instruments ready for difficult tumors. Now, this is an algorithm which we have developed for tumors which involve the cavernous sinus. And I'll first talk a bit about meningiomas, and then we'll talk about other tumors. So with the meningiomas, the questions are the same. Is it a soft or a firm tumor? What are the collaterals? What are the patient's cranial nerve deficits? Is it a primary or recurrent tumor? And has the patient received prior radiotherapy? And the questions with regard to the tumor itself are, is it arising from within the cavernous sinus? Was it arising outside the cavernous sinus and invading the cavernous sinus secondarily? And lastly, is it a recurrent tumor after prior radiotherapy? And I'll show you some examples of the different ones. The goal with these two categories is if you elect to do the surgery, we try to remove the tumor completely when it is safely feasible. So what does that mean, safely feasible? That means that you can remove the tumor without damaging the structures there. On the other hand, if the tumor happens to be firm or densely adherent to certain structures, leaving tumor behind and giving radiotherapy or radiosurgery. However, with the recurrent tumors, you have to have a much more aggressive approach, and we'll see an example of that. Now, with regard to other tumors involving the cavernous sinus, then you can be more aggressive. For instance, chordomas and chondrosarcomas, we try to achieve a complete removal whenever possible. Very rarely, if it's a recurrent tumor, you may have damage to the carotid artery, in which case bypass may be necessary. Trigeminal schwannomas, some people think that these do not actually involve the cavernous sinus. They do only when they get to large size. Otherwise, they stay in the Meckel's cave. And just about all of these patients, you can get a complete removal. Now, with regard to malignant tumors, such as squamous cell, adenoid cystic carcinoma, osteosarcoma, etc., if the tumor removal is oncologically beneficial to the patient, that means that by removing the tumor in that location, we can achieve a good oncological result for the patient, then the tumor removal is performed. ICA bypass will likely be needed, and skull-base repair is very important to prevent CSF leakage. So this is just a compendium of tumors involving the cavernous sinus that we've operated in the last 15 years. And you can see different kinds of tumors here. And the major complications are listed here. 3 major infections, temporal lobe or subarachnoid hemorrhage, both 2 cases which resolved. 2 patients with inophthalmos, which required immediate correction. 2 graft occlusions, both were revised successfully. And 2 carotid artery injuries, which required some type of grafting. And 1 patient with brain infarction, which improved, and this was due to a graft occlusion, which was revised and then successfully, but in the meantime, the patient had a small stroke. No cases of CSF leak and no deaths. And cranial nerve functioning, some have gotten worse, but we are just studying them in detail so that we can enlist them for papers. So my recommendations regarding these tumors have the evidence level 3. So we don't have randomized trials. We don't have case control trials. So they are based on experience. And so you need to look at your own results in your center and then your own expertise and develop your methods. And I'm only giving you my recommendations based on my experience and results. So I'm going to show you a series of illustrative cases. This is a patient with a recurrent cavernous hemangioma. You can see that this is a high density lesion on T2 weighted imaging. This patient had prior attempted removal. She presented with proptosis, right eye pain, and headaches, and on steroids continuously for 4 years. And she had a very poor vision in her right eye with a subtotal cranial nerve 3 paralysis. And now the vision was being involved in the left eye as well. And we performed an angiogram in this patient to mainly see where was a carotid artery, which is pushed down anteriorly, as you can see. And you can see the blood supply. And these are pretty vascular lesions. They do respond to radiotherapy as well, but this is a fairly extensive lesion. So we decided, and this patient has very poor collateral circulation, as you can see here with the cross compression study. So in this patient, she was operated by the combination of both combination of a superior and lateral approach to the cavernous sinus. And here you can see this is a right-sided approach. There's a lot of scar tissue. And we are doing extradural posterolateral orbitotomy and anterior clinoidectomy. And we are opening the dura mater here and a fair number of adhesions, and then opening the sylvian fissure and dissecting it more. You can see that. And so we are approaching the cavernous sinus on both sides. So we have proximal control. And we have made preparation for bypass in the sense that the radial artery has been prepped but not exposed. And now we see the superior and lateral walls of the cavernous sinus. Here's the third nerve, second, and the carotid artery. These are just outside the cavernous sinus. The tumor is actually extending outside the cavernous sinus. You can see the cranial nerve 3, and we are now opening up the lateral. As you can see here, there are no clear triangles, and all we can say is that this is the junction of the superior and lateral surface, this one. And you can also see that the tumor is very vascular, and one has to deal with it more or less like an AV malformation. You sort of have to come around it and isolate it from surrounding structures. So we're just working now on the medial aspect of the, so I like to do what I'm doing here, a combination of bipolar cautery and dissection with a suction in the left hand. Sometimes we use what's called a three-handed approach, that is assistant providing either suction or traction. So here now we are in the lateral wall and the tumor is extruding from the lateral wall of the cavernous sinus. So we now are dissecting the tumor. Of course, here is the third nerve. The fourth nerve has already been damaged during the previous surgery, and the patient has fourth nerve paralysis. We do try to find the fourth nerve. In this case, it was not relevant to the patient, but it's only important for anatomy. So here, the tumor is extruding back toward the clivus, posterior surface of the cavernous sinus. And we are now again dissecting the tumor away gradually and coming to the carotid artery, which is the critical structure in this patient. We know from the angiogram that the carotid artery is anterior and inferior in the cavernous sinus. And we are, here is some bleeding and it's from intracavernous sinus venous bleeding. So that can be stopped with some fibrin glue, as you can see here. I've designed a special long needle, like a spinal needle, but with a blunt tip for injection of the fibrin glue. You can also inject powdered gel foam, as I mentioned earlier. And here you see the ophthalmic division of the cranial nerve 5, which is very critical to preserve. This is the meningohypophyseal trunk feeding the tumor. You can see that the carotid artery is somewhere in this region. And we are using a microdoppler probe also to help with intraoperative localization. And posterior clinoid. Now we see cranial nerve 6. And I'm just moving it along. Tumor section from the preclival area. I mentioned that the tumor has invaded through the posterior wall toward the clivus. And here we are, the tumor is more or less completely isolated and removed. And again, we're checking the carotid artery. The posterior clinoid process there is shown, etc. So this patient, this is toward the end of the procedure, and you can see the various nerves, the third, this fifth, and so on. And one thing I frequently do is place something on the lateral wall of the cavernous sinus and suture it so that the bleeding, if any, is contained within. And this patient has what appears to be a complete removal, but there could be a remnant here. And if this is the case, the patient will be followed, and we could treat this with radiosurgery. And she actually had somewhat improved cranial nerve function. She is totally independent, and she actually takes care of her husband, who's disabled. So here's a different case, an intracavernous meningioma, pretty small. And this is a patient who was seen initially by his ophthalmologist with a small tumor. He presented with mild third nerve weakness, but over a period of 6 months, he had significant growth of tumor. So this is a tumor which has started inside the cavernous sinus, and he presented with oculomotor paralysis. And so he was operated by predominantly the superior approach, as you see on the right side. So here is the left-sided operation. And again, we are opening the sinus, and here's the optic nerve. And anterior clinoid, there is already tumor extruding from the sinus. And this, we are just removing the portion that is outside. And then we are removing the clinoid, the remaining anterior clinoid, intradurally. And then once that is done, we can go, so here we are injecting some fibrin glue to stop cavernous sinus bleeding. And then we are able to go inside. So the last piece of the anterior clinoid here. And third nerve is just a little lateral to the anterior clinoid. So this bone has to be removed and sent for pathology as well, because it's often invaded. And now we are inside the cavernous sinus. All right. So we are now removing the tumor here inside the cavernous sinus. So we are able to go through the superior wall and remove the entire tumor in this patient completely. You can see that. And complete removal was accomplished in this patient. And you can see that here, his cranial nerve palsy was resolved. And this is a WHO grade 1 tumor, and he was able to return to work. So the next case is a very extensive cavernous sinus tumor. and middle fossa tumor. She presented with progressive diplopia for 6 years, but adjusted to it. More recently, she had abnormal sensation of hair in the right eye. On exam, she had a complete fourth and sixth nerve paralysis and diminished sensation. And MRI scan shows a giant intra and extra cavernous tumor. You can see here, this is a tumor that is extensively invading the middle fossa and the cavernous sinus. And the patient had adjusted to the sixth nerve paralysis for a long time. So her main concern now is the brain compression and losing remaining vision in the right eye, in that eye. So here you can see the preoperative embolization. We were able to do some embolization because of the external carotid artery feeders. And during surgery, I was able to remove almost all of the tumor, but I left a remnant around the anterior portion of the carotid artery here. And post-operatively, her cranial nerve function was the same as pre-op after her recovery. And we are planning radiosurgery for this remnant. Now, the last meningioma that you'll see is what we call the worst case scenario. This is a patient who started with a tumor inside the cavernous sinus, and she went to London and was treated there by fractionated radiation for this tumor. But the tumor kept growing, and she developed a complete paralysis of the cranial nerves, and the carotid artery is completely encased. You can see that here. And she presented to us with continued growth of the tumor and no vision in the left eye and complete ophthalmoplegia. Now, when we do an angiogram, the problem here is that she has a completely isolated left carotid circulation. You can see that the carotid artery is not only encased, but also narrowed, and there's no cross flow from the other side. So this patient is totally dependent on the carotid artery in the left hemisphere. Any damage to this will result in a major stroke and death. So how to deal with this type of tumor? We do it in 2 stages. So the first stage was a bypass procedure. In this case, we did double bypasses. Probably this is, in my opinion, nowadays overkill. We probably had one good functioning high flow bypass would be enough. But in this patient, we placed a radial artery graft from the external, and then with that functioning well, then we placed a saphenous vein graft to the other branch of the middle cerebral, a double bypass to the middle cerebral. And then we went in and did a complete tumor removal, and then used some muscle and fascia to reconstruct the medial side, because as I mentioned earlier, we need to close the entrance to the sphenoid sinus so she doesn't have a CSF leak. And follow up, this tumor has not grown, and she has the same function as preoperative. So this is really an oncological resection. And one more quick case, this is a patient with a petroclival and cavernous sinus meningioma, large petroclival and cavernous sinus is invaded as well. But in this patient, the issue here is that he was operated in 2 stages. He actually had a very firm tumor. So we are initially an extended Transylvian approach. I won't go over the details of this operation. And we removed the top 2/3 of the tumor, and then we use a transpetrosal approach to remove the lower 2/3. And this is the transpetrosal approach. And he was still left with tumor inside the cavernous sinus. This was a very firm tumor, not easy to remove. So we left this, and then we treated him with actually fractionated radiation in this patient. He could have had radiosurgery, but the radiation oncologist felt it'll be better to have fractional radiation. And he remains free of tumor recurrence. He has a partial right third paralysis, but it's almost normal. but he has a trigeminal nerve deficit, which is the main thing that he has. He is fully functional and returned to work. So this illustrates a case where we electively left tumor because it was very firm, hard to remove, and with the idea of functional preservation. Now, this is a patient who present with a disabling trigeminal pain and ischemia after receiving radiation. So here's a patient who presented initially with left ear pain and trigeminal neuralgia and double vision. And on neurologic exam, he had diminished vision in the trigeminal distribution, and he completed radiation therapy for this. So he had presented initially with this tumor, which is mostly inside the cavernous sinus, and he had radiation therapy. However, for post-radiation, the trigeminal pain really became very, very severe. And he was also developing ischemic symptoms. You can see that cerebral blood flow studies showing diminished flow in the left hemisphere, and also he has some small strokes involving the left hemisphere. So what to do with this patient? So the patient here, the tumor is not growing, but the cranial nerves are symptomatic, and you can see severe narrowing of the carotid artery as it goes through the cavernous sinus, and he has not very good cross flow from the other side. So what we did here, we did a stage removal. Initially, we did a partial, I don't want to go through this video, but basically we ended up decompressing the trigeminal nerve. So peel the lateral wall away from the trigeminal nerve to decompress it completely, open up the Meckel's cave. And also we did a bypass using anterior tibial artery because both radial arteries, saphenous veins were not very good for him, very good in him. So we used the anterior tibial artery to do a bypass. And this improved his condition remarkably. Patient's cognition improved, and also his pain improved remarkably. So this is something that one can consider simply a decompression of the cranial nerves before you submit the patient to radiotherapy. Now, moving on to other types of tumors. This is a patient here with an extensive chondrosarcoma involving the cavernous sinus and the petroclival area. So this is as you can see, the chondrosarcomas are more laterally located, and this here goes down along the clivus, and the cavernous sinus involved. A case like this, definitely one can remove it completely by this patient at a left subtemporal and infratemporal approach, and the tumor was removed completely. So we decided not to give him any postoperative radiotherapy, and is simply being followed. This is another patient, but now with a chordoma. This is an 18-year-old girl. She had 2 previous operations in Canada by transmaxillary approach, by a palate splitting approach, transmaxillary approach, etc. But tumor was never removed completely, and she has both a central tumor, but also extending laterally into the cavernous sinus. She already has a left abducens paralysis and difficulty swallowing. She has a palatal prosthesis and a nasal voice. So you can see that the tumor is both central and lateral. So the operative plan for this patient was the combination first of a lateral approach via a subtemporal and infratemporal approach, middle fossa, with a resection of the lateral portion of the tumor. I won't show you a lot of the details, but this is a lateral approach. We are cutting the zygoma, and we are then working in the cavernous sinus, both intra and extradurally. And this is the tumor inside the cavernous sinus being removed. So we are and liberating the carotid artery completely from the cavernous sinus and closing that space. And then we come back, go back to the previous. Let's see, yeah. So we, in the second stage, we performed an extended septal approach from the front for removing the remainder of the tumor, and a complete removal of the midline portion was performed. And this patient, let's see, missing a post-op imaging. You can see this is a post-operative image which shows the complete removal of the tumor. And this young lady has been able to, she graduated from culinary school, she's become a chef, and she has no tumor recurrence. And you could see a very good result despite all of her issues. This is a patient with a giant chondrosarcoma, a young man, 19-year-old. This was incidentally discovered after a motor vehicle accident, but he, on exam, had a partial 6 nerve paralysis and headaches, and 1 TIA with an episode of right arm weakness. And you can see that the tumor is very heavily calcified, and the carotid artery has a very tortuous course through the tumor, and the cross circulation is not very good because the connection is just through a small A1 segment. This is very important information to have before the surgery. So we made preparations for potential bypass, in this case, thinking that if we need to, we'll have to do something. So here we have exposed the tumor. This is a supracavernous carotid artery. And we are opening the cavernous sinus through the lateral wall and peeling and then identifying cranial nerves to see where we enter the tumor. So a portion of the tumor was easy to remove, was soft. However, a large pieces of the tumor were bony. You can see that here. And we are removing pieces. There are a lot of bony involvement, invasion, ossified tumor. And here we are using Sonopet ultrasonic bone curette to remove some of that. But as I tried to move the tumor away from the carotid artery, you could see, lo and behold, it's a massive carotid injury. So here we compress it digitally and stop the bleeding. You can see just with finger pressure, stop the bleeding, and then put temporary clips, proximal and distal. Here's the cervical carotid exposure, putting temporary clips, proximal and distal. And here we have a clip on the vessel. And then what I did was we have radial artery exposed, doing the radial artery bypass in this case. You can see here the distal artery being sutured. And this is the radial artery graft being sutured to the M2 and then taken down to the ECA. And so once we've done this, we stop the operation because he's had a carotid injury. Here's the external carotid artery injury. And we come back, we check post-operative imaging, is a well-functioning bypass and no evidence of ischemia. So we came back and then removed the rest of the tumor. You can see a near complete resection has been accomplished. And the patient actually, except for 6 nerve paralysis, is in good shape. So I would like to stop the operation. This is a patient, by the way, with multiple aneurysm. This is a large supraclinoid, giant aneurysm, then large MC aneurysm. And then she also had basilar superior cerebral aneurysm, presented with subrectal hemorrhage, treated here with the bypass and then clipping of the rest of the cases. But This is vascular surgery, so I'm not going into this. So in conclusion, surgery of the tumors involved in the cavernous sinus requires exquisite skill, judgment, and compassion towards a patient. What is compassion? Compassion is to give the best result for the patient, not for yourself, because we all know what you can do. You know better than anybody else what you can do. So both a combination of vascular and skull-based techniques is required in order to perform good surgery inside the cavernous sinus. Newer treatments based on anti-tumoral antibodies will become available, and we will use them as they come available, because once again, our goal is to achieve the best result for the patient. It's not necessarily surgical, maybe something else. And lastly, this is just a nice picture from Seattle. This is our former President Obama showing Indian Namaste. This is the best way of greeting in the present coronavirus world. Namaste. Namaste to all of you. And it's also Buddhists from Japan, Korea, wherever you are. Namaste to everyone. And I appreciate the opportunity to give this lecture.
Thank you. Thank you very much, Professor Sekhar. It is a very great talk, not only about the general aspect of the cavernous sinus tumor, anatomy and surgical tips, but also you show us very difficult cases. And it's amazing to find the very low complication rate in your cases. So I very appreciate your talk on this topic. So can I ask some questions to you?
Please do, yes.
Okay, yeah. Firstly, about the cavernous hemangioma. Yeah, I have some cases of cavernous hemangioma in this part, and it's very vascular rich, as you suggested, and sometimes a lot of bleeding. So you did microsurgery very elegantly, so we couldn't recognize the difficulty of the hemostasis, but would you tell the younger colleague how the difference of the way of hemostasis between meningioma and the cavernous hemangioma?
Right. So the cavernous hemangiomas, the main thing is that they tend to bleed, and they bleed a lot. And there's no, the only way to deal with the cavernous hemangioma is you deal with it like an AVM. So you sort of expose the surfaces that you can expose, either superior or lateral, and you come around it, but you have to recognize that all the blood supply is coming from the carotid artery. So once you get to the carotid, if you can cauterize and occlude the vessels, the bleeding will stop. But when you have blood bleeding, just use a bipolar. You can use cottonoids to use some pressure. Don't go inside the tumor, unlike a meningioma, where you're going inside the tumor. You debulk, or a schwannoma, for instance. I didn't show any schwannomas, but same thing. We can go inside. Here, you have to stay outside, like an AVM, essentially.
Okay.
And the bleeding can be quite frightening. So, don't be afraid. You try to come around. Yes.
Okay. So if the tumor is very huge, sometimes difficult, but yeah, I would follow your suggestion. Yeah.
One thing you can do, if the patient has collateral circulation, in this case, he had no collaterals, you can put a temporary clip on the carotid artery during the early part of dissection, just to reduce the bleeding. That can be done. Yeah.
Okay, good. And what is your idea about the gamma knife for the hemangioma? Some reports say that.
I think gamma knife is effective. I believe it is effective. For smaller tumors, I think one can use it. But when you have a very large tumor, then it may not be a good thing, because you also have neighboring optic nerve, and you may make some of the cranial nerves worse. So I think for smaller tumors, definitely gamma knife. I also, by the way, for the last 3 years or 4 years, I also performed some gamma knife radiosurgery. I took the course finally with my colleague, Dr. Lunsford in Pittsburgh. I'm also involved in some gamma knife cases. And we work together with radiation oncologists here as well, because I found that I'm sending patients to them for, either AVM or tumors to gamma knife. So I go, and so we have some good discussion, and they know what we can do and we know what they can do.
Okay, thank you. And my next question is about bypass. I completely agree that bypass procedure technique is very critical for managing these tumors. So my first question is, I think it's very important to predict preoperatively the extent of the carotid invasion or the risk of the bypass procedure, requirement of the bypass procedure. So would you tell us the standard diagnostic way, maybe MRI or DSA or?
Well, the first thing is to discuss about anytime you are working in the cavernous sinus, or if the tumor is encasing the carotid artery or severe displacement, you should have some idea about the collateral circulation. Now, in the past, we used to do balloon occlusion testing and so on. We don't do that anymore. I simply do an angiogram with a common carotid compression, and just to see if there's a good ACOM and a good PCOM. Now, if you have a young patient and they have a good ACOM and good PCOM, they probably will tolerate permanent occlusion. What is young? I would say 45 or less. But anyone older, even if they seem to have good collaterals, if there is a carotid injury, then we perform bypass, because some cases you can have watershed infarction. So in the old days, we used to do the occlusion testing and blood flow and all those things. I don't do, because my goal is, if there is injury, we're going to do a bypass just about all the time. Now, if you're going to do a bypass, you need to be prepared for it. So that depends on different levels of preparation. So what does it mean? If you feel that you are definitely going to experience carotid injury, there's a high risk. Like the last case that I showed, the chondrosarcoma with a lot of bony changes and the carotid artery, and I felt that that's a case, there's a high risk of carotid injury. So in such a case, I even exposed either the radial artery saphenous vein. I have proximal, distal, everything ready to go so that we can do it quickly. Usually we can do the bypass about maximum 1 hour and 15 minutes of temporary occlusion, usually less than 1 hour of temporary occlusion. Lastly, if you have a case of malignant tumor or recurrent tumor where you know for sure you have to get the carotid artery and the tumor out, then we do the preemptive bypass. And I would say that at least in my experience, always I prefer to do what I call a high flow or moderate flow bypass using radial artery saphenous vein, sometimes anterior tibial artery. However, if you have a large STA, that's also adequate. More than 1.2 or 1.3 millimeter size STA, you can place it to the M2 or M3 vessel. That may be enough if you have some collateral circulation. So that's something that, so this is what I want to emphasize, that for the young neurosurgeons and a little bit older surgeons like myself, every case is a new case. Your experience only matters to some extent. When you walk into the operating room, this is a new patient for you. And that patient is your God. So you need to deal with the patient like you're dealing with God. And you have to do the best for the patient. However, a lot of skill and training is involved. Recently, we have published a paper in Journal of Neurosurgery. I don't know if some of you have seen that. It's called the Home Microsurgery Lab. So in this day, we are all isolating ourselves. We cannot go to the lab with the COVID. So we found that everybody, all the young people, our residents and young neurosurgeons can build their own small lab in their home using some very, inexpensive, maybe not, I don't know how it will be in India or Japan or Korea, but small set of tools. And you can spend 1 hour every day or a certain number of hours every week practicing, even if you're not a bypass surgeon, if you can maintain your microsurgical skills, this is very important, I think, for the young people.
Yeah, I agree with your opinion that the training is very, very important, even for the very senior neurosurgeon. Okay, yeah. Going back to just one question about the bypass. Going back, you said that if the patient is young and the good collateral, okay.
Yeah.
So do you accept only the STMCA, prophylactic STMCA, and the occlusion of the carotid for the very
young
good
patient,
collateral? Yeah.
If they have good collaterals?
Yeah.
Yeah, if they have good collaterals, you can do only STMCA will be adequate. Yeah.
Do you use any monitoring of the MEP or something?
Yes, we are monitoring always SSCPs and MEPs. And if you have any local regional blood flow monitor, you can use that also. Yeah.
Very important. Thank you. So my last question is about the how to reconstruct the sphenoid sinus. If you talk a little bit about it, so could you tell us?
Always, I think that it is important to have two layer of reconstruction. So we like to use some very good fascia. You can use, if you have good temporal fascia, you can use that, but our abdominal fascia and some fat. And it should be encompassing. In other words, it should be bigger than the defect. And you need to place it and suture on all the sides, and also use a fat graft. It's very important to, most important thing is to recognize, sometimes when you're doing anterior clinoidectomy and optic nerve decompression in our center, frequently it is done by my resident and our fellow, and I'm just supervising. But if I do it all, but always I tell them, the most important thing is when you're finished, look at the space around the optic nerve. It can be used sometimes above, but it's coming through the optic strut. There's a hole, and we have had some cases the person didn't recognize that there was an opening. Of course, you can see this in the preoperative CT scanning. If you look at the preoperative scan, you can find it. And of course, if you do a complete removal of the cavernous sinus tumor, whichever approach, if you're coming from the lateral side or from the medial side, that opening is there, so you have to reconstruct. Otherwise, you could have done extremely good work, but then what's the point if the patient has CSF leak and infection? That's a big problem.
Thank you. Professor, I found one question from the chat, and there is one question about the antiplatelet agent. How long do you use the antiplatelet after the use of bypass?
Bypass, usually just about, if you have a good functioning bypass, 3 months are enough, but the patient can continue for, if it's just an aspirin, one baby aspirin, they can continue to take for a long time. But generally just in the perioperative period, 2 to 3 months are enough if you have a well-functioning bypass. And frequently some of our patients, they keep taking baby aspirin. Somebody says, well, we need to do endoscopy, we need to do, so we stop it. Nothing happens, so it's not like having a stent. Oh, that's one thing I didn't talk about. The question of whether you should, let's say that you have meningioma and the carotid artery is encased. Can we place like a pipeline stent and give the patient some time, because you have to wait minimum 3 months, maybe 6 months before you can do treatment. But that's a potential approach. If you have time, you can think about that. Another thing is that what happens, let's say you're doing transsphenoidal surgery, the carotid artery is encased and some damage, how to deal with that? In my opinion, the better way is to do a bypass, but some of my colleagues have used flow diversion stents, and we've gotten into trouble also. We have one recent case where a patient had 3 flow diversion stents placed, and the patient came back and the stent clotted off, and the patient had a stroke. So it may be a temporary solution, but I don't think a permanent solution.
Okay, thank you. I didn't think about the stents, but I get some idea. So, Professor Sekhar, so thank you again for today's opportunity, and we learn a lot from your lecture. So,
Thank you, professors.
almost time, so I would like to
We'll open the platform for discussion with the audiences, right? With your permission. So
I recognize number of my very good friends from India and around the world. I'm saying hello to everybody, and yes.
Please, Professor Muthukumar, would you like to come in, sir?
Thank you, Raja. That was a wonderful presentation by Professor Sekhar. I don't have any questions or comments. Thank you so much.
Thank you. Professor Dwarkanath Srinivas.
Yeah, sure. Good morning, sir. How are you?
Very well. Dwarkanath, good morning.
I just had a small question regarding the use of going for second stage surgery. What's your experience on the hemostasis? Because after you do the first surgery, do place the patient on anticoagulants for some time.
Antiplatelet.
Yeah, antiplatelets. And when do you go in for the second surgery? Do you wait for some time or?
No, it doesn't seem to actually, the main problem with antiplatelet therapy is the epidural bleeding. Inside the dura, not so much. So if you get very good hemostasis epidurally, then everything is okay, but you have to spend a lot of time to be very careful with epidural hemostasis. It seems to be that's the main issue, epidural. And I have some patients even on dual antiplatelet therapy, only cases, malignant cases, where they have some hypercoagulable condition. But usually we have just on one, only aspirin. But if they don't respond to aspirin, we put them on Plavix or clopidogrel. Yeah.
Dr. Ajit Sinha, would you like to come in, sir?
Yeah. Good morning, sir.
Good morning.
I learned a lot from you, and I always follow you very closely. So my question is that you showed very excellent collection of cases and very good results. But nowadays, even the transnasal endoscopic work, people are doing quite elegantly and quite extensively. So even they are removing the. I am especially talking about the chordoma patient which you showed. So can that be done through the transnasal route? Because even people are trying the tumors which are extending lateral to the carotid, and they are doing it quite effectively.
Yeah, well, I think it's a very good question. The main problem that I see with tumor extending lateral to the carotid is that when you have carotid injury, it is very difficult to do anything other than carotid occlusion. To this date, I am not aware of any method by which you can repair the carotid artery by a transnasal endoscopic approach. The only thing you can do is to occlude the artery and hope that the patient's collateral circulation will take over. Or you take the patient to the endovascular suite and try to put a pipeline stent. Or you take the patient, you flip the patient and then do a bypass. So I think that if you feel comfortable that you can just remove the tumor and maybe, leave something. And even in the Pittsburgh series, what they found is that by a transnasal approach, the risk of injury to the carotid artery is higher in cases of chordoma and chondrosarcoma that involve the cavernous sinus. They routinely use a transpterygoid approach to expose the carotid artery in the petrous carotid and then go up and so on. So I feel that, in my hands, and I think in case of many surgeons, what I would recommend is if the carotid artery is extensively involved, a transcranial approach is better, simply because you have the ability to do something immediately if there's carotid injury. Because the last thing you want is a patient, that carotid is injured and has a stroke or death or whatever. So that's my opinion. Obviously, if the tumor is soft, like a pituitary tumor or even a chordoma, you can remove a large portion of the tumor from that side.
So regarding, like you mentioned, and that I am very much impressed with that everybody should have some arrangement at home also, small arrangement for doing a practice of bypass and all. Can you just elaborate what all we require for that?
Yes. By the way, there is, if you can go to Journal of Neurosurgery, it has just been published online. The paper, I will send it to one of you. It's already published, and we have assembled, along with two of our residents, Dr. Josh Abekasis and Rajiv Sen, and then Dr. Ellen Bogan. So we actually, at least in the US, about $800 it required to have the microscope and the setup, and also we have outlined some of the exercises that you can do. Basically, the idea is not new. We've all been working in the lab for a long time, but now we are not able to go to the lab because of this situation, and may continue for another year or so. But even if you go to the lab, you have to go, you have to make a special time for that. So my idea was, well, can we do this at home? And for those who are from India, let us think back 5,000 years ago, that Sushruta, he was the father of surgery. And what did he do? His students, they were called Shaushrutas. They were asked to practice on fruit and vegetables and dead animals and then cadavers. This was the paradigm. So what we have suggested is exercises starting on fruit, and then and chicken wings. You can buy chicken wings and practice various techniques. So this is something that, and we've also described that you can have X number of hours. Now we are working on some milestones, how each individual, but it doesn't matter what the other person is doing. You are your own competition. So you know where you are. So are you improving? That's all, that's what we need to do. And as I said, even for senior surgeons, let's say that, I haven't done an STMCA bypass for 5 or 6 months, and I have to do an STMCA bypass. So what should I do? I need to maintain my skills. So even for senior people, I think this could be a nice way.
Professor Hidehito Kimura.
Thank you for your excellent presentation and showing your elegant surgical techniques. So I'm also a vascular neurosurgeon and a scholarly neurosurgeon. So I totally agree with your surgical strategy. And we should perform the bypass, place the bypass prior to the cavernous sinus, so invaded the tumor. So we should not hesitate to perform the bypass surgery. So I totally agree with the surgical strategy. So I have also one small question for you. So, if you perform the staged surgery for the large cavernous sinus tumor, so what is the optimal timing for the second surgery after the bypass installation?
I usually wait about 2 to 3 days.
2 or 3 days.
But you can do even 1 week. I just want to make sure the patient wakes up and is recovered from the first surgery and anesthesia. No more than, you don't need to wait more than 2 or 3 days.
Mm-hmm.
But even 1 week is okay. You want to go back before a lot of scar tissue has formed, so.
Yeah. So I have one question for you. Okay.
Mm-hmm.
So you have also published the so famous article saying pressure distinction technique. Yeah,
Yes.
Yeah, and do you monitor the pressure during the pressure distinction? So because,
no, I do it visually. So we push, and then we see that popping of the. Yeah, we have not monitored the pressure during pressure distension. Yeah, some people ask the question, is it damaging the intima? We have not seen that happen with the damage to the intima. Yeah.
Appropriate attention, not excessive. Yeah. Thank you.
Thank you.
Namaste.
Sir S.N. Mathuria.
It was an excellent talk as usual with Dr. Sekhar. Hello, Dr. Sekhar.
Good morning, sir. Good evening.
Regards to you, and really a nice and concrete answer to each and every question which have been asked. We'll go through the article which have been posted also.
Thank you very much.
Thank you.
My great pleasure.
Dr. Vignesh.
Hello, sir. It's always been a pleasure listening to you, and this time it's been no different. It's always been an eye opener every time we listen to your lecture. Thanks a lot, sir. I have nothing much to ask, but it's been a very lucid presentation.
Yes, my co-host Liu.
Professor, thank you for a very nice presentation. I just wanted to find out from Professor, because generally for young people, we were taught that those pure cavernous meningioma not to touch because of the advancement in radiosurgery. And Prof has shown us many cases with surgery without any additional damage to the cranial nerve. So my question is, how do we select patient? Whether we should select those with already deficit or without deficit, and what the criteria that we can go in safely. And for the opening up the cavernous sinus, is identifying the cranial nerve early is very crucial in this procedure, and whether always professor we trace the nerve distally towards the tumor to identify the cranial nerve early, and whether during this procedure individual cranial nerve been monitored for this procedure. Professor.
Thank you. So the question has many parts to it, but I'll talk first about cranial nerves. So the simplest part of the surgery, cavernous sinus surgery, is performing the peeling of the lateral wall to decompress the cranial nerves, and the removal of the anterior clinoid and optic nerve decompression from the other side, so we can enter the sinus through the superior approach. Now, that every microsurgeon who does skull-base surgery should be able to do. Now, whether to go inside the sinus and remove the tumor will depend on the consistency of the tumor. So if the tumor is soft, I think one can do that easily. But if the tumor is very firm and hard, I think you should stop, So that's the first point. The second one is that anybody who performs surgery in the cavernous sinus should be prepared or able to do some type of vascular repair. Don't want to be working around the carotid artery that is encased, and then you have an injury, what to do? So no, you should be able to do. If you can't do it, you should have a colleague, cerebrovascular surgeon, who can do something, so that's important. The next question was about young person training, etc. I think that there is no substitute for the various steps, lab training, anatomical training, and then, training in the operating room. One should not go into the cavernous sinus as your first operation or first, you should have some experience with skull-based surgery. Yeah.
Yes, your ex-fellow Sneha Chitra is here. Sneha Chitra, would you like to say hi to Professor Chitra?
Very good morning. Such a pleasure to hear you again. Reminiscing my days
You
back.
in Pondicherry now? Pondicherry?
I know I'm in Chennai, sir.
Chennai,
back in
okay.
Chennai. Yeah.
Okay.
I'm reminded of my days at UW, and I'm sure to send a lot of the juniors. I'm going to put a word to spend some time with you, sir, just for all the inspiration. Thank you very much.
Thank you, and I'm so happy to hear from you.
My dear friend Satish Kannan.
Hi, Professor. It's an excellent lecture. Again, it was just reminding me of the days when you came to Chennai for the meeting at MGM. It was really nice. Thank you, Professor.
Yes.
Very nice. It was very nice to be there, and also, to be, and I remember when I gave lecture, and also my best regards to Dr. Krish.
Yes, sir. Sure. We'll pass on the message. Thank you, sir.
Sir Partharthi Datta.
Namaste, sir. I am from Kolkata. Regarding the case where you showed there was a accidental carotid injury, and you put the carotid on this temporary clip on two sides and did a bypass.
Yes.
So what measures were taken to just prevent the ischemic complication during the time of bypass?
That's
Because
a very
that was
good question. Yes, that's a very good question. One thing maybe I should have talked about a little bit, I didn't go with this in detail. So anesthesia for complex cavernous sinus surgery and surgery where you were expecting carotid injury is also important. And I say that you should have an experienced neuroanesthesiologist. What does that mean? That person should be, first of all, the patient is being monitored, SSEPs and MEPs. Secondly, any blood loss should be replaced. Third, we raise the blood pressure 20 to 30% over the normal blood pressure for the patient. And we place the patient in burst suppression using propofol to reduce the metabolic flow. And if the occlusion is prolonged, you can put them on a small dose of heparin as well. We give intravenous heparin, usually 3,000 or 4,000 units during that time, if you feel like the occlusion time is prolonged. Of course, always the key is to be prepared, and what to do if you're not prepared. Let's say that you are working by transsphenoidal surgery and you're not prepared. I mean, there's not a lot you can do other than to stop the bleeding and then, do all the other things. But the brain protection, raising the blood pressure to improve collaterals, all these things are important. Very, very important to have the whole team behind you. So the anesthesia, your assistant, the nursing, these are all very important people, for you.
Sometimes a tumor involves bilateral cavernous sinus.
Mm-hmm.
Bilateral. In that case, what approach you will take to address the both sides?
Yeah. So it depends on the kind of tumor. Obviously, if it's a chordoma or chondrosarcoma, or something like that, I prefer, it depends on also, is this the first time or, another time? I prefer an approach, what I call the extended subfrontal approach, going, through the midline with carotid control, but I will not go into the other cavernous sinus for the first time, and try not to deal with both carotids at the same time and then come back. I have some patients, both chordoma and meningioma, in whom bilateral bypasses have been done, but not at the same time, different times. They had recurrent of tumor. So I have one patient not too long ago, last year or so. She had a bypass first on one side. She came with recurrent tumor. She had proton beam radiotherapy, this and that. Nothing, the tumor was growing. So we had to do the other side, and she's okay now. God knows how long she'll be free of tumor, but she's doing well. So I have some patients like this, bilateral bypasses have been done. But generally, I don't try to deal with both carotids at the same time.
So thank you very much, Professor Sekhar and Professor Fujimura. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank today's speaker, Professor Laligam Sekhar, and the Chair, Professor Miki Fujimura, who accepted our invitation and spared valuable time to support this educational venture of the ACNS for the benefit of the young neurosurgeons and the residents. I thank all the attendants who joined for today's session. So until next Wednesday, it is bye-bye from all of us.